Yeah, good afternoon, Vivek.
Good afternoon, sir.
Yeah, I feel we wait for 5 minutes and then we'll start. Huh?
Yes, yes.
Yeah, no issues. Yeah, very good afternoon to all of you. I'm Dr. Amit Mamre, Professor and Head of Department at EIPMR Mumbai. So I would like to welcome Dr. Vivek Chavate, who is currently working as Associate Professor and Head of the Department at KJ Sumaya Medical College, Mumbai. He has done his post graduation in AIPMR Mumbai, and followed by he has also worked as a senior resident and held professor of assistant professor at AIPMR. His interest is in neuro rehab, pediatric rehab, musculoskeletal rehab, and interventional pain management. He has also worked sometime in the Daradia Institute of Pain Management. So I welcome him. The topic for today's seminar is evaluation of management of cerebral palsy in spastic diplegia. Over to you, Vivek.
Thank you, sir. Thank you so much. Today, I'll just share my screen and then start talking. Is my presentation visible?
Yes, sir, it's visible.
And am I audible properly, right?
Yes, perfectly.
Thank you, thank you. So today our topic is evaluation of management of cerebral palsy. Actually, it is a very vast topic, and uh, every aspect of CP management has a lot of depth and detailing in it. Today, I have tried to cover up at least touched every point. And the detailing I have not done, but for the sake of simplicity of understanding, I have tried to cover up everything. Basically, we'll start with definition. So cerebral palsy is described as a group of permanent disorder and development of movement. So the problem is development of movement, and nature of the disorder is it is a permanent disorder. And it is like, what is the pathology? It is a non-progressive disturbance or injury. It is a non-progressive, that it will not increase with time. That injury has happened to the developing brain, that is fetal brain or infant brain. Nowadays it is the third part of the definition. The motor disorder is also associated with or accompanied with disturbance in sensation, perception, cognition, communication, and behavior by epilepsy or secondary musculoskeletal problems. So epidemiology is around 2.11 per thousand births, and it has remained almost constant in spite of various new techniques of monitoring the patient, antenatal checkups, ultrasound techniques, but still the prevalence has remained more or less the same. Then what are the main risk factors of etiology? The like, it can be divided into five parts. Pre-conception, it can be maternal seizures, intellectual disability, thyroid disease, age older than 40 years. Then antenatal problems like birth defects, small gestational age, low birth weight, placental abnormalities. Intrapartum, that is during delivery, birth hypoxia, mucinum staining, prolonged labor. During neonatal stage, like the baby develops some complications like seizure, respiratory distress, hypoglycemia, and postnatal, that can be stroke, abusive head trauma, or bacterial meningitis. Uh, then there are many classifications of CP, like how we are going to describe CP. So the classification is where at least six are mentioned in our textbooks, and still, like, ongoing process is there to improve this classification. So the first classification is topographic or distribution wise classification, how the impact of the CP has been distributed on the patient, like hemiplegia or quadriplegia. Then comes the motor science. So whether it is a spastic, dystonic, that kind of classification. Then surveillance of cerebral palsy classification tries to combine the first two types of classification, that is topographical and motor science. So it will say spastic monoplegia CP, monoplegic CP, or spastic diplegic CP, something like that. Then the fourth one is totally dependent on gross motor function of the. So, what is the function of the patient? Then the faceted classification tries to uh, combine the other problems. Other problems means like cognitive issues, seizure disorders, or sensory perception disorders. So the multifaceted classification system is trying to combine all the problems in one classification. Then as we all know, we are shifted from International Classification of Disability (ICD) to ICF, International Classification of Function. So, but for pediatric age group, the functioning is different, like playing with his classmates, or going doing school activities. So a separate classification has been formed, which is International Classification of Function, Disability, and Health for Children and Youth. So up to age of 18. So there are many domains in this, and we have to classify the patient as per these domains. Again, to this thing, topographic or distribution based classification, that is hemiplegia, quadriplegia. Hemiplegia is involvement of upper limb and lower limb of the same side with cerebral palsy. Then quadriplegia is involvement of all four limbs with cerebral palsy. Then diplegia is involvement of bilateral lower limbs. In motor science, there can be positive motor science, or negative motor signs. So, in positive motor signs, it can be increased tone or movement disorder. So, in hypertonia, spasticity can be there, dystonia can be there, rigidity can be there. Or in movement disorders, hyperkinesia, or we call it hyperkinesia, dystonia, chorea, athetosis, myoclonus, tics, and tremors can be classified. Then negative signs, they include weakness, reduced movements, then apraxia and ataxia. Then surveillance for cerebral palsy in Europe. So they have classified it as a unilateral spastic CP, bilateral spastic CP, dystonic CP, choreoauthorized CP, ataxic CP, and non-classifiable. Then most commonly used these days is gross motor function classification system, and level one is mild impairment, but the patient is independent. Then level two is slight assistance is required, but overall the patient is independent. Level three, he may be dependent on gait aids or wheelchair, but usually he manages his independence. Slight support is required in few activities. Uh, Level five, level four, a good amount of support is required. Many of the activities the patient won't be able to do, and he will be dependent on powered wheelchair or a person assistance for his activity, basic activities. And level five, most of the activities the patient is dependent. Then international classification of function, disability, health for children and youth. So again, there are few domains in that. That is body function domain, then body structure domain, then activity and participation, environmental factors, and personal factors. Then diagnosis. So diagnosis is particularly dependent on the history and examination. Then we try to exclude other diagnosis, and finally a neuroimaging may be supportive to our diagnosis. So basically it is diagnosis of exclusion, and then we establish that it is a cerebral palsy case. So the typical image that we get on neuroimaging is periventricular leukomalacia. So I have just given an example of that. Then history, in history we should cover the basic birth history to find out what was the problem during the birth. Then developmental history to identify when the patient achieved the milestones, various milestones. Then regression of milestones, so they are also important. And functional history, okay, what are the areas which are lacking so that we can work on those areas. On examination, three main examinations which are like to be focused as the neurological examination, musculoskeletal examination, and functional examination. Neurological examination primarily to identify the pathology. Then apart from that, musculoskeletal examination to get the picture of how, where is the spasticity, what are the limbs that are contracture, there is contracture, and what is the pattern of involvement of the limbs. Then and functional examination, ki what all functional level the patient is in, and what we can so that we can plan ki what we can improve on function. Then motor signs and patterns. Now there are usually these patterns which are usually seen neonatal pattern, that is the patient is hypotonic initially for first maybe 2 years, and then he develops spastic patterns. So the first pattern, the hypotonic pattern, is called neonatal pattern. Then then the patient might develop bilateral lower limb spasticity, uh, may show posture like crouch gait or jumper's gait. So then we have to say, like we will identify it as a diplegic pattern. Then sometimes patient shows one limb involved and one upper limb and lower limb involved, one sided. So it will go in hemiplegic pattern. And uh, all four limb involved with truncal involvement or tonicity can go in the quadriplegic pattern. Usually, hemiplegic pattern and quadriplegic pattern appears, or the injury is associated during full term period, and diplegic pattern occurs when the injury happens during preterm or early in the gestation. So now on history examination, we know ki the most likely diagnosis is cerebral palsy. So then the question comes ki whether neuroimaging has been done or not. So if during neonatal period there it is not done, we should go for MRI, mostly MRI. We will find periventricular leucomalacia. But so what is the use of this MRI image is, now if we get the image is like the pattern is hemiplegic, and the image is also correlating with hemiplegia, or one-sided periventricular leukomalacia is there. So that means ki some sort of hemiplegia or stroke has happened. So coagulation profile is also required. If the MRI is normal and still we are suspecting CP, then more workup on whether the problem is genetic disorders or metabolic disorders should be done. So that's why MRI is required after the means, like if it is not done during the visits, it should be recommended. Then prognostication. So the commonest question or the basic question that the parents will ask us is, will my child be able to walk? So there are two aspects to it. Okay, what we can do to improve this particular patient, and we can talk about the statistics also. Okay, what is the statistics that the patient will be able to walk? So after clinical examination and understanding the function, understanding the musculoskeletal problems or picture, we can decide that yes, he may require surgery, he may require bracing, and by that bracing, we will be able to make him independent in, like he will be a home ambulator or community ambulator accordingly. And as far as statistics goes, uh, if the patient is able to sit independently by 2 years, then there is a good chance that he will be able to walk, sit or crawl per se. Then if the patient is having less than 3 primitive reflex by 2 years, uh, then it is also a good sign that patient will be able to walk. Now, if the patient is not able to sit by 4 years, then it is less likely to walk. The percentage that 80 to 90% of CP diplegia are able to walk, 50% of CP quadriplegia are able to walk, and 75% of dyskinesia are able to walk. Then, as per GMFCA scale, the level 1 and level 5 usually remain same. Level 2, 3, 4 tend to improve with time and intervention. Then, research on prognostication regarding factors like activity and participation are still awaited, lacking. Then management. So management can be divided into basically three parts: medical management, therapeutic management, and orthopedic management. So medical management basic goal is treat the comorbidities and to improve function. Now, usually, as a pattern goes, more the severity or more the GMFCS level, the more will be the comorbidities. But there is an exception, that is pain can be prevalent irrespective of the severity. In GMFCS 1, 2 will have good amount of pain and behavioral issues. So even milder motor involvement may have behavioral issues. Then feeding, growth, and nutrition. The very important problem is dysphagia. Now, dysphagia directly difficulty in swallowing. So, dysphagia directly can be a cause of nutritional deficiency, and which is associated with many medical complications like growth disturbance, increased infection rates, skin breakdown, and osteopenia. and finally that leads to decreased life expectancy. Then some cases the feeding time itself is too long, so it increases the caregiver stress and effort. So then as far as management goes, we should look for clinical signs of dysphagia like weight voice, low weight, then chest congestion post feeds. A proper solo study and therapy should be started. Change in food consistency is recommended. Then nutritional supplement, uh, uh, as nutritional supplementation is also recommended. Then some cases gastrotomy tube improves safety, like safety in view of aspiration. Then oral hygiene and sialorrhea is also a very common problem. So proper oral hygiene, frequent dentist visit should be recommended. Then for management of sialorrhea, anticholinergics can be given like glycopyrrolate, or sometimes injecting Botox is required, or sometimes surgical interventions are required. Then pulmonary complications. So important cause of they are important cause of morbidity and mortality. Recurrent aspiration and infection can cause permanent structural damage to the lungs. So the preventive strategies for pulmonary complications are important, like dysphagia management, then control of sialorrhea, then reduction of gastroesophageal reflux. Uh, Regular chest physiotherapy and bronchodilator use. If the patient gets pneumonia or pulmonary complication, antibiotic use should be proper. So by after uh, proper culture sensitivity testing, the antibiotic therapy should be tailor made. Then sometimes prophylactic antibiotic coverage is also required. Then immunization against respiratory pathogens should be done. Then upper airway obstruction may need CPAP or upper airway surgeries. Lower airway obstruction may require bronchodilators and pressure ventilation. Sleep apnea can be one of very common occurrence in such patients and should be ruled out and treated. Then scoliosis surgery may improve with restrictive lung disease. Neurological issues. Commonest problem is seizure disorder. So, by around 30% of patients suffer with seizure disorder. And then again, anti-epileptics that we use here may cause cognitive dulling. Then the next problem is cognitive impairment. So, maybe identified in almost 50% of the individual. But before we label or focus on cognitive impairment, we should rule out is it without with due to some other problems, like in basal ganglion lesion, the patient will develop dysarthria, and usually the cognition remains normal, but problem is speech. So we don't identify it as a like we are not able to assess cognition properly. Then similarly, we should rule out hearing and visual impairment. Again, mood disorders may also appear as a poor cognition. Then genitourinary problems. So avoiding dysfunction may be due to poor processing of the sensory feedback. So patient is not able to understand the sensory feedback, or poor motor control. Then detrusor sphincter dyssynergy might be there. Then usually continence is achieved. The time is usually delayed in patients with CP, and CP is associated with increase in chances of UTI. Then other problems are vasourethral reflux related complications. Then again, levacitram may also cause renal calculi. So we should be having a surveillance, or we should be watchful for such complications. Gastrointestinal reflux diseases and constipation are very common in patients with CP, and the discomfort and pain due to this may also cause increase in undertone. So, keeping these problems in control is very essential. Musculoskeletal pain and osteopenia. Due to less mobility, and there is a increased risk of contractions. Then common site of pains are usually spine, hip, knee, foot, and ankle complex. Then pain associated with aging is also there, like in due to patella alta, spondylolysis, spondylolisthesis, and degenerative hip condition. Osteoporosis is usually due to poor mobility and poor weight bearing. Anticonvulsants and malnutrition increases. Malnutrition is there, and decreased sun exposure. So, should be looked out for osteoporosis and treated with calcium and vitamin D supplementations. Therapeutic management. The patient should like therapy is very beneficial for patient with CP, and they should get therapy in a with multidisciplinary team approach, where the multidisciplinary team, child, and the family members are all involved. Then patient require professional therapy, but it can be administered in different ways, like in specialized centers, or maybe schools, home, or via tele rehabilitation or community based centers. So whichever way, the patient should receive therapy. There are basic therapeutic approach. The basic like stretching, strengthening, and aerobic training are very useful for the patient. There are other specialized therapeutic approach like bobath, that is neurodevelopmental therapy, ayers, domans, and uh, cato, patterning therapy. It is also called patterning therapy. Then roots, vojeta, and conductive education, constraint induced movement therapy. So these are kind of specialized therapy that can be used. Then complementary and alternative treatments for cerebral palsy. So hyperbaric oxygen, ideally suit patterning, then electrical stimulation, threshold electrical stimulation, hippotherapy, and acupuncture therapy. These are the therapies that can be used as a complementary or helpful therapy. Then durable medical equipment. The patient with CP may require wheelchair, sitting devices, then gait aids, and splints, then and augmented communication devices. So we should be, as per required, we should be prescribing that. Then management of hypertonia. So the hypertonia is one of the most common problem in cerebral palsy. So we can approach it by oral medications like baclofen, or diazepam, tizanidine, clonidine, or dantrolene sodium. So and also we can have focal interventions, like we can use Botox, or we can use phenol or alcohol block. So uh, phenol and alcohol is usually targeted toward the nerves, and uh, Botox is usually targeted at the belly of the involved muscle. So when the problem is very focused, like only gastrosoleus is involved, only one gastrosoleus is involved, or one particular muscle in hand is tight, like pronator teres is tight, then we can focus Botox in those group of muscle or that particular group of muscle. But when the problem of spasticity is widespread, then either we have to go for oral medications, or we have to look for options like intrathecal baclofen. So intrathecal baclofen is technique where a pumps via a catheter pumps a small amount of baclofen directly into the thecal, that is CSF. So it significantly reduces the spasticity with very less amount of drug that is required, with less other side effects like drug related side effects. But the procedure is costly and is also associated with some complication. But long term, if the patient is that amount of the spasticity is involving too many muscles, then such interventions are useful. Then deep brain stimulation is placing an stimulating probe into the basal ganglia, and the stimulator or the controller is placed in the pectoral region, subclavicular region, and the firing of that controller can reduce problems like dystonias and choreographed movements. Then there is a technique called selective dorsal rhizotomy. So it is done by doing multiple level laminectomy and identifying the rootlets from L2 to S2. And some percentage of dorsal roots are severed. So the spasticity is reduced, but it is also associated with decreased strength or weakness. It is also associated with the weakness of the muscle. Sometimes even ventral roots are targeted in case of dystonias. But like selective dorsal root rhizotomy has a long-term good outcome, but it should always be supported with proper therapy for strengthening of the muscles. Then orthopedic management. So there are basically four types of surgeries: release and lengthening, then tendon transfers, osteotomy, and arthrodesis. So basic goals of the surgeries for level 1, 2, and 3 GMFCs is to improve ambulation and or maybe hand function also. And level 4 and 5 is usually to improve care and comfort. So for like perennial hygiene and reducing pain related to hip, so surgeries are targeted that way. So usually the single event multi-level surgeries can be done or separately as per required, like only ankle foot is in contracture, so you can target that particular area only. Usually it is done after the age of 7 to 9. Before 7 to 9 it is recommended that the contracture prevention or all that effort should be from therapy or medical via therapeutic and medical strategies. But like if the surgeries are done before 7 to 9, there is a good chance that the relapse will happen because of due to bone growth, and so the contractions can reoccur. So these are the soft tissue surgeries you done in lower limbs. Usually hip related hip flexors, iliopsoas, proximal rectus femoris, and rarely sartorius is lengthened. Then adductor group, hip adductor lengthening. Then adductor longus, gracilis, adductor brevis can be lengthened. In around the knee, hamstring lengthening is very common. Medial and lateral hamstring is done. Then an ankle foot, gastrosoleus or tendo-achilles tendon lengthening can be done. So either aponeurotic, only aponeurosis can be cut, or the ender tendon is cut and done with joined with Z lengthening. So these are the soft tissue surgeries that we usually do. Then soft tissue surgeries in upper limb. So shoulder related shoulder joint stabilization or improving internal or external rotation. Then elbow, again joint stabilization surgery. Forearm, usually there is pro- pronator teres contracture. So pronator rerouting or lengthening can be done, or entire flexor pronator origin is released, that can be done. Then wrist, again stabilization procedures can be done. Then thumb, again stabilization procedure or flexor polyceps lengthening procedures or reinforcing with external polyceps longus can be done. Then finger flexors, again finger flexor deformity usually is there. So FDS to means flexor digitorum superficialis to extensor digitorum can be done. So these are the few surgeries that are recommended for upper limbs. Then usually the surgeries are to be delayed as much as possible, but except for one, that is hip. So hip surveillance is very important, and hip subluxation is very common with CP. So there is a Australian hip surveillance guidelines that in 2020 that are usually recommended. So few common, like I have summarized this in one slide. It is a book, like a big guideline. So basic few common things are the migration percentage is very important. Sorry, actually there is some noise disturbance from outside. I just changed my place. So I have tried to summarize the guidelines. The commonest points are migration percentage of the hip are to be seen. If it is greater than 30%, surgical interventions are most likely required. Other things to be aware of is the pain in the hip and other muscular conditions are there. Then we should try to do X-rays and try to identify whether surgeries are to be required. The other muscular conditions include development of hip deformity or increase in limb length discrepancy. So we should be in the lookout. So it is according to GMFCS classification, and usually grade level 1 of GMFC, the child should be screened at 24 months, 3 years, and 5 years. Usually, no X-rays are required; only clinical examination is required. Then for GMFC 2, the child should be examined at 24 months, 3 years, and 5 years. On 5 years, an X-ray should be done. If the migration percentage abnormal, then yearly follow-up X-rays are required. For GMFCS 3, 24 months and every year X-rays are to be done plus clinical examination. Then for GMFC S 4, 24 months onward, every 6 monthly X-rays are to be done. If the migration percentage appears to be stable, then yearly X-rays are to be done. If it is not stable, then 6 monthly it is recommended. For GMFCS 4, again 6 monthly X-rays are to be done. Then there is a classification for hemiplegic limb or hemiplegic patients, because the hemiplegic patients has a tendency for hip dislocation in later in their life or during nearing when they are nearing puberty. So Winter, Gage, and Hicks classification, where group 1, group 2, group 3 are like involvement of foot, involvement of knee, and group 4 is involvement of hip. So hip is spastic, going in flexion or adduction. That is group 4. So the hip surveillance is only recommended for group 4. Because they tend to hip dislocation later in life. So review at 5 years with X-ray. If everything is okay, there is migration percentage is normal or below 30, then nothing to be done. Then monitor at 10 years. After 10 years, yearly monitoring is recommended till the skeletal maturity achieves. So you can see that peel in the left side figure, the line P is the line where beyond which the hip should not be subluxated. So the total width of the head of the femur and that line. So that A and B is into 100, that is percentage. So that is amount of the head of the femur is subluxated in this particular case. So that should not be more than 30%. Then this is the right side image suggestive of how the X-ray is done. Then causes of hip dislocation. It occurs due to muscle imbalance, lack of weight bearing, progressive varus angle of femur neck, and anteversion over pull of medial hamstring. Then again, there is a classification for CP diplegia. So the group 1 is only involvement of uh, gastrocnemius. So ankle foot angle is greater than 90 degree. So it is true equinus. Then group 2 is where the ankle foot and hip is also involved. Knee and hip is also involved. So there is ankle foot plantar flexion, then knee flexion and hip flexion. So that is jumper's gait. Then group three is only the knee is involved. Ankle foot is maintained in 90 degrees and hip is also involved. So you will see early heel off during stance phase. So it is called apparent equinus. So there is no actual equinus, but due to knee flexion, it appears like equinus. And then there is crouch gait. So there is hip knee flexion, but ankle dorsiflexion, and sometimes the tendo Achilles is lengthened, means over lengthened due to stretch. Then group four is asymmetrical gait. Other deviations can be scissoring gait, femoral anteversion, medial hamstring spasticity, adductor spasticity can be seen. Then stiff knee gait can be due to overactivity of rectus femoris during swing phase. Then spine. Scoliosis is present in 21 to 76% of CP patients. It's proportional to GMFC skill. So more GMFC, more the chance of scoliosis. Then it can be divided into basic two patterns. The first pattern is small curves in ambulatory patients with no pelvic obliquity, and other pattern is large curves in non-ambulatory patients with pelvic obliquity. Then 6 monthly to yearly monitoring during puberty. No correctable, non-correctable deformities of greater than 40 degrees can be fixed with instrumentation. Then aging with CP. So MSK issues associated with degenerative changes in joints with aging are there, and as the age progresses, energy consumption is high, and easy fatigability and increased pain depression is very common. So these are the various aspects of the patient suffering from CP, like various complications and comorbidities. Thank you.
Yeah, thank you, Vivek. It was a nice presentation.
Thank you,
You
sir.
have touched almost all aspects of CP, right from infancy to adulthood.
Thank you, sir.
Uh, it's very difficult to cover such a vast topic in such a short time. But I thank you for doing it. If there are any questions, you all can please go ahead and ask. Dr. Vivek will be there for you. So, Vivek, I just wanted to ask you, like in KJ Somaya, do you all get CP patients also in the OPD?
No, no, very less
Okay,
patients.
no issues, no issues.
Hardly any, hardly any.
No issues. So, but still, uh, 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 still have a experience, lot of experience from AIPMR.
Yeah,
So
yeah,
here there were mainly lot of CP patients which
yeah.
were there, and you have seen them here. So I just wanted to ask, like, once, we normally don't frequently see adult CP patients, or mostly in the patients, the CP which are there, even in AIPMR, we don't see them in their
That's
40s
adult,
maybe, or
adult
in their 60s maybe. It means we have not seen patients
same.
progress. Like
Yeah,
maybe in our life, in the career span is still less. So one, the child who comes, he
yeah.
doesn't progress to that age. But still means, have you encountered any in the general population, a patient comes for pain and all and associated with CP, that way I'm saying. So
No,
how in general.
hardly any encounter. Like
Okay, okay,
what maximum I have seen is reaching the adulthood, 2022. But
okay,
they were like they came specifically for gait problems, never for like pain or early arthritis problems.
There is a question in the chat box. I'm not sure when can we give graph. Most probably it's a gra- I feel it is FRO, flow reaction orthosis, GRAFO. I'm not sure. So it's a flow reaction orthosis. Maybe the question is GRAFO. I'm not sure. Gravity assisted foot orthosis, or most probably it appears to be
Uh,
like a flow reaction orthosis.
So, like in wherein we have weakness of dorsiflexors or comparatively the gastro, like the problem is dynamic and the contractures per se are not established in case of CP specifically. So, and the dorsiflexor are weak, and so ground clearance is means during swing phase it is causing problems or increase hip knee flexion. Then we can recommend the flow react this GF flow reaction. Per se flow reaction we don't use na. I
But
think
I suppose that GRA for even I am not
means we
I've
usually
not
use it for
been term.
knee weakness,
Yeah.
but
But
in
yeah, you're
CP
right.
per se, I don't know.
We
Okay,
can use it, I suppose, if they have good hip extensors. If
yeah,
at all the hamstrings and the plantar flexors have some amount of power, but there is weakness in the quadriceps maybe,
quadrus.
and there is no knee flexion deformity as such.
Yeah, yeah.
So in such cases, you can use them. You can
Uh,
use them so that basically what happens is if there's no deformity and the crouch is there, and as you said, dorsiflexors are weak, but the plantar flexors are good, then in
yeah.
such cases we can use if there's no equinus deformity and all, then you can use a flow reaction orthosis, I suppose.
Yes, yes, yes.
That's
But such kind of specific picture is
Yes,
difficult to
it's rare,
find. Yeah,
but that
yeah.
way we can use it. But provided that they have some power in the hip extensors, maybe the hamstrings, maybe they are not contracted and their control is good. And the plantar flexors, they are spastic, but the control is good. They are not. If there's no equinus deformity, the
Yeah, yeah,
dorsiflexors are not powerful.
yeah,
Then
yeah,
it
yeah.
would help, I suppose.
Yes, yes.
I feel if there are no questions, then uh, uh, okay, there's one more question. Why does bowel and bladder disturbance occur in cerebral palsy?
Per se, uh, they have not clearly mentioned in the text, but as with every neurological involvement, the bowel and bladder is also having a central control. So, any injury, brain injury, like CP is basically a sort of brain injury only. So, the higher functions are taken up by the lower centers. So higher centers are not effectively working. Lower centers are working. So spinal level centers are working, and so that again will cause muscle related problem controlling the sphincter may be difficult due to increased spasticity in the bladder. Though it will cause dysenergy or early emptying of the bladder or the CP patient may not understand the signal that is going up. Like if the bladder is full, the sensory processing might be problem. So this causes the incontinence. So usually that is causing the bladder disturbances in CP.
Yes, Vivek, as you rightly pointed out, but I also feel that most of these patients don't have a problem with the control of bladder or bowel. They have maybe constipation. They have maybe the frequency is more.
Yes.
So and the problem also lies somewhere because of their spasticity. There is not much of a movement. So maybe the spasticity is one element which could affect the movement. If there is no movement, the patient, let's say, assume the child is stationary, maybe, or he moves less frequently. Then also it would contribute to his bowel habits. As such, the control is present. He knows that he has a control to pass motions, he has a control to urinate. Only problem is the urgency is there in case of bladder, and maybe the more of a constipation is there in case of, and that too in all, not all patients have that. maybe if you say let's say in 100 maybe 10 patients would have those, or 10 to 20% patients would have those complaints.
Yes. Apart from that, their ability to communicate, their ability to understand cognitively,
Yeah.
social awareness. So that also affects
So it
the.
depends on the level of brain involvement also, which could be there
Yes.
basically. So if there are no other questions, then I like to thank Dr. Vivek for taking his precious time and giving us this wonderful lecture. And thank you, Dr. Vivek.
Thank you, sir. Thank you so much,
Yes,
sir.
yes. And I would like to thank all the attendees who have attended the seminar. Thank you to all of you. Yeah, thank you.
Thank you, sir. Thank you.
Madam, we'll end the session.
Yes, yes, yeah. Thank you so much,
Oh,
Vivek.
sorry,
I'm
ma'am.
so
I didn't
sorry.
know you were there. Continue,
Oh,
please, ma'am.
अच्छा मैडम मैंने सोचा अस्मिता को बोलो, so
नहीं
sorry.
नहीं या सॉरी, मैंने देखा नहीं आपको
नहीं,
स्क्रीन
I
पे,
just
सॉरी.
joined late. I am so
Yes, ma'am.
sorry.
नहीं नहीं नहीं.
But
He had
it
given
was
our lecture. I feel the next topic is also there. It's advances in orthotics by
yes,
Dr. Priyanka. Yes, the screen is showing. 12th of February.
which is 12th February. So
Yes.
we have the 12th February our IAPMR. So maybe we'll change the date and we'll get back.
Yeah, sure, ma'am.
No?
Sure, no
Yeah.
issue, ma'am.
So then
No issue.
yes, we will
Yes.
circulate
We have
the
to change
flyer and
basically. Yes.
thank you, Vivek.
Thank you,
And
ma'am, for
thanks,
giving the
Amit, for taking
opportunity.
it.
Yeah. Thank you,
It was
ma'am. Thank you. Yeah.
yes.
Bye.
Okay. Thank you, everyone. Bye.